Old days, we did these by hand. When I got into medicine, they were already done vis-a-vis automation. So it's not something, and so this is, why don't I see you here now? So we would look at these white blood cells. And so I want to tell you about the white blood cells, and I want to tell you about the ABO system, and we'll save clotting for another time. White cells, they're the only really true cell of the formed elements because they're a cell. They're considerably less. As you can see, I mean, there's about 1,000 times more red cells per microliter than there are white cells. So they're fairly easy to see. And so what I have are slides, and the microscopes, I understand, are down there. And you can, all you do is you put them under high dry, and basically you count arbitrarily. So you guys should break yourself up into 3 groups and count the first 30 you see. Do like a grid search, back and forth, back and forth, back and forth. Side. It's all, no magic. It's the way we used to do it. We used to have a little device in the lab, and you would just click lymphocyte, neutrophil, lymphocyte, basophil. If you saw one, they're rare. So that's why I want to show them to you. And what's neat about them is we can see them. We're going to look in the bloodstream. They typically, and when there's inflammation or damage, when we talk about this in the immune system, they work their way by enlarging the interstitials, the intercellular spaces, and they can kind of, because they can sort of squeeze their way through. They can change shape with the chemicals that are there. It's like you and I getting, it's a tight door where I might have trouble squeezing through. Many of you would not. You get the idea? Or you're getting through right away. Okay. So the white cells, typically we count them. I'm not expecting anybody to be abnormal. The stain that we use is called Wright's stain, WRIGHT''S. And there's 2 families. Ones with visible granules, ones that do not. And understand, visible is the key word. They all have granules. It's whether or not we can see them. Again, it's like striations. We call them that way if they're visible. So you have granulocytes and agranulocytes. And surprisingly enough, of all the stupid mnemonics in the world, that one actually works. I think it's poor. I think it's people for the ethical treatment of monkeys would be concerned about not giving them bananas. But this is the batting order. Neutrophils first, most abundant. Lymphocytes second, monocytes third, eosinophils fourth, and basophils last. So that one actually works. That's the one we were taught, medical school. Go with it. And so what we're looking for, again, remember when we were doing the spin down about these things, this was in that particular area. There's a limited amount. There's more platelets, much more so than I'm saying. Yeah, knew that was going to happen. So neutrophils, eosinophils, basophils. So you can see where they are. So the granulocytes are ones that have visible staining granules, and they either, if they're acidic, they stain red. If they're basic, they stain blue. If they're neutral, hence the name neutrophils, they stain a neutral kind of a color. Okay, it's almost like a lilac. They've talked about historically. This is what they look like. Do not get that. It's hard not to get them confused. A lot of people see basophils in their sleep, when in reality, they're looking at lymphocytes. You've got to see the granular forms. If you see one, call me over because you may be looking at a lymphocyte. They're just, every other year I actually see one. They're on these slides. They're just hard to find. There aren't that many. This is the famous neutrophil. It's called a polymorphonuclear leukocyte. That's what we attack bacteria with. They're known as bacteria slayers. They are elevated in a bacterial infection. They're supposed to be. And so it's one nucleus. It's just folded. Again, it's like making balloon puppets. You fold it, and if you see anywhere between 3 to 6 segments, you know it's a poly. Both The eosinophils and the basophils, if you can see the segments, have two. The eosinophils, which I'm sure you will find one or two of, have these reddish, distinctly reddish stained granules. The basophil, they're just filled with these blue granules. So the granules are critical. Here are these, they call it, is that lilac? I don't know. Sorry, I'm still, when I get these different favorites like lipsticks, it's like, really? My foundation is a little bit different. Thank you. Bless you. 3 people smiled. The rest of you, Jenna, you got to wake up for these jokes occasionally. What? It's all right. My wife has heard all of these jokes when she was a student. She said, "You're not funny at all." Stop. This is the kind of disrespect that I get. The agranulocytes means we can't see them. If you see a cell that's all nucleus and it's blue, it's a lymphocyte. If you see one that has a big nucleus with either a cutout like that they describe as U-shaped or kidney-shaped and it's big, that's a monocyte. They become macrophages. They all are in the bloodstream. When they leave the bloodstream, neutrophils stay as neutrophils, eosinophils stay as eosinophils, lymphocytes, which are mostly T cells, by the way, that you'd be seeing in a peripheral smear. Look this way. When these leave, they all stay the same. The basophils typically become mast cells that are so important when we get to immunology for allergies, and the monocytes become macrophages. So it's important to know what they are. Larger and shorter lived. Remember, red cells, 100 to 120 days. Lobed rather than circular. Granules very specific, all are phagocytic to some 50 to 70%. Twice the size of an RBC. Good. I'm trying to address 2 things at once. So they call it the respiratory burst. Remember we talked about toxic derivatives of oxygen? What they do is they release chemicals. They synthesize these oxides, reactive oxygen species, and basically bombard the bacteria, the microorganisms they're in touch with. Okay? Defensin granules merge with the phagosome, little spears that poke holes, and then it's amazing that a cell does this. It pokes holes with it, and then it shoots toxic derivatives of oxygen. I wish I had thought of that. Really, I say it facetiously, but it's absolutely true. How clever is that? So now you can see what they look like. EOs, 2 to 4% average. Nucleus has 2 lobes in a broad band, look like earmuffs, red staining granules. The enzyme there, they're very abundant, not only in allergies, but particularly in parasitic infection. Worms, malaria would be an example. The one who's texting me had a condition as a baby called eosinophilic gastroenteritis. He was more allergic, but he had an abundance of eosinophils when they did a scope of his gut at the old Children's Hospital. Well, this many years ago. And he's always had a certain amount of digestive problems, but it gave us a diagnosis. Okay, so in this case, it was allergic as well. Allergies and asthma as well as an immune response. And here they are. Red granules are the key. Basos, hard to find. Purple, 1 or 2 constrictions, typically one in the middle. Histamine particularly, very similar. These are really important when it comes to allergies. So a lot of this is because we do this again in the lead-in. So what you're going to do is look under the microscope, divide yourself into 3 groups. You guys divide into 2 groups. Happy dance, and have somebody look at them and have somebody keep tabs. Okay, and we add them up at the end and see what kind of result we get. Normally, you get an abundance of neutrophils and lymphocytes. There's no right or wrong way to do it. If you're not sure what it is, that's why I'm here. High dry works fine. So the agranulocytes, can't see them. Lymphomonas are hard to miss. Lymphs are your elevated in viral infections. It looks just like a giant nucleus with a little rim of cytoplasm. By and large, they are T cells that you will see circulating. We'll get into the distinctions that are there. Immunology is good. You don't have the course with Dr. Maurer this time, but I mean, I'll do a pretty thorough job. I like that topic. Mono is the largest. That you are indented or kidney shaped, become macrophages. Really significant in a lot of things. So when you hear about mononucleosis, it's mononuclear forms. It's not just monocytes that are elevated, it's monocytes and lymphocytes. If you have a slide with someone with mononucleosis, a relatively common problem, particularly a common problem in college students and high school students. I mean, it's an infectious disease. It's spread, typically through saliva. It's a herpes infection. If you didn't know that, relatively common. I was talking about them today with my micro classes. They are, the problem is, as kids, yeah, you just, which you are, pardon the expression, as young folks like you are, 3 to 6 weeks, you're basically better. The older you are, or if it's recurrent, it really gets bad. One of the guys who was a junior resident under me, probably 28 years old, when oh my God, like 3 to 6 months, he was a mess. A mess. My first wife got it at age 38. If she'd had it when she was in nursing school, and she would be around your age. I told the class sitting, I'll tell you, she was in bed for around 6 weeks. All she could do, thankfully, the bedroom and the bathroom were right next to each other. When my kids were, I had 3 kids in diapers at that time. I had to hire full-time help to take care of the kids and her, and then come back and do it myself when this lady went back to her kids, who thankfully were old. Because I was still practicing throughout the day. That was 1989. So this is what they look like. See them again. There's a lot of different things. When we get to immunology, we're going to talk about interleukins. We'll talk about colony stimulating factors. The 2 lines, and this is where leukemia comes from, are lymphocytic. Okay. Are lymphocytic versus myelogenous. So the myeloid line is the line with the granulocytes. The lymphoid line is the ones with the lymphocytes and monocytes. So when you hear about leukemias, you either hear chronic lymphocytic or acute lymphocytic, chronic myelogenous or acute myelogenous. That's how it's diagnosed. They do a bone marrow aspiration and take a look and see what's in the bone marrow. I mean, a peripheral smear might tell you. And so they go through all of these. What happens, the worrisome part is this. Those, what they call those ABS ones, those are band cells. If you're putting out too many immature forms, there's something like a tumor in the bone marrow that's making that happen. And immature forms have one thing in common: they can't fight infections, viral, bacterial, parasitic. So the way it was explained to us by a pathologist in my residency, he said, think of it as troops are coming out that are untrained. It's like you're fighting a big battle, and all you're doing is putting out troops who aren't prepared to do the battle. And that's why they look at those types of things. There's so much information that you can get, and that's a complete blood count, which I showed you. Doing things like that, a urinalysis, complete blood count, a comprehensive medical panel, you get a lot of information in a big hurry. Big hurry. And they go through all these that you don't have to know. And really, this is what they're trying to show you. So these are when we see immature forms here or immature forms here, bad news. But the mature forms we want to see, and you're going to see, this is the macrophage, and now you're going to see the change into whether they're forming a plasma cell or a T cell. We'll go into all of that type of stuff. Very important. That's immunology. That's after break. You don't have to thank me. That's our next lecture unit. I consider it the hardest lecture unit. So get your partying done early. Come back ready to go. You know who you are. Yes. I'll be watching. We'll be babysitting on St. Patty's Day, so my granddaughter can party. It's fun. So These are a lot of these, the erythropoietin we talked about, colony stimulating factors we'll talk about when we get into immunological diseases because of bone marrow and cancer and all of those things. Okay, there's a lot to it. So here's what they are. If there are too many, leukemias, infectious mono. If there are not enough, leukopenia. Typically, that's something that occurs when people are on long-term cortisone and particularly on medications that suppress the bone marrow. Anti-cancer drugs being a poster child. For this, so many antibiotics can do that as well. So there's a lot of those. I'm not going to go into the idea if that's the cancer, etc. Acute, primarily children, bad prognosis. Chronic, older, better prognosis. So there's a lot of different, they have to be treated. They've been around forever. I told you about that wonderful book that you certainly could read if you're interested in the topic of cancer, called The Emperor of All Maladies. It was a Pulitzer Prize winning book from about 2010, where he looked at it, and really when he started looking, leukemias were some of the first things they were looking at. He was almost like a biography through the ages of cancer, a very interesting perspective on that. I heard the guy on TV, fascinating. So that's what happens. They crowd out the other cell lines. And they put out immature and non-functional forms. All of that's possible. And there's lots of things, the ways to treat it. We have bone marrow things. Highly contagious. It's a herpes virus known as Epstein-Barr. Did you learn about that in micro, guys? Yes, no? A little? Okay. To understand what that is, that's one of the many herpes viruses. That's human herpes virus 4. Okay. And this is what happens. Think of what happened. You're putting out, these cells are not able to do their job. So they can't, and because of that, you're tired, you're achy, it's hard, your spleen is overwhelmed. You can, I mean, if you do go back to activity when you start to feel better, you can rupture a spleen. That's really what the difficulty is. You have to be very careful. Young people, 3 to 6 weeks, because instinctively you feel better. I want to go back and I'm going to do the sport I like to do. I'm going to go back and go full bore. Can't do that. So 4 to 6 weeks, typical. Well, we're not doing platelets today. That's what we're going to do next time when we get together, probably for lab next week. We'll work on that because I don't want to do homeostasis is really something we don't try to do here. I'm trying to get all this in. And we'll do all that stuff with platelets and growth. Remember we were talking about that platelet-derived plasma, everybody? That's where it comes from. These growth factors, very significant. We didn't know anything about them. I knew nothing. They never told us this 50 years ago. We started to hear about all of these growth factors, nerve growth factors, all of these factors around late 80s, 1990. I remember going to a surgical seminar at Hershey at the medical school, and it was like, people are, you're getting stuff pulled out, and you're like, oh my God, that makes so much sense. All these things that we were doing, okay, why we were doing things, and all of a sudden explained a lot of the science and this is molecular biology. I have no idea what this child wants to kill me. So I'll go into all of that, and we'll go into the homeostatic things and petechiae and purpura. And if showing lines, just don't show off. Nobody fucking cares. Hemophilia, DIC, transfusions. No one is better qualified to talk to you about transfusions than moi. Because I've had, like I said, about 50 units of other people's blood. My hemoglobin was about, you saw it is now. It's never come back to normal. It was about 5.5. When I eventually had surgery, I had to be in the hospital. It was that after I'd gotten a 3-unit transfusion and was still trying to practice and teaching part-time. That was 1990. That was right around 2000. So that was one of those times I came pretty close to not being here. I was in the hospital for 9 days to get healthy enough that they could operate. Then I was able to go home for a couple of days, and then came back and I was in for another 10 days. Like basically late May and June was I just lived it down at St. Margaret's in Aspen. Transfusions now are much safer than they used to be. And maybe I mentioned in passing, my first wife tests positive now for hepatitis C, which means she has antibodies to it, which means she was exposed. Most likely, they discovered it because she got a blood splatter running a nursing home. Basically, she was the nurse in charge evenings and weekends at a fairly large nursing home over in Wilkinsburg, which is now like a senior citizen housing place. So I think they discovered it there, but the transfusion I think they did it was in 1981 when she was having a surgery called wedging the ovaries we were trying to get pregnant unsuccessfully, but and she had a big bleed inside, so they gave her a couple of units. Up until 1987, blood was not thoroughly screened for hepatitis C and HIV. We didn't know enough about them. My guess is she got it there. Normally, you would have expected me to test positive for it. I did not, interestingly enough. So I think she was exposed limitedly, as her health is unfortunately not nearly as good as mine these days. And we all see each other as a family all the time with grandchildren and great-grandchildren. My kids basically, because she's disabled now, my kids basically take care of her health needs. And basically, the doctor said, "Look, if she gets really sick again, we have to keep an eye on this Hep C." Thankfully, there are treatments now that are better for hepatitis C. There were not before, so that's one of the good things happening in modern medicine. So on with the show. The safest blood you can get is your own. So a lot of times you're doing elective surgery, cosmetic surgeries, certainly are part of it, facelifts, things like that. I don't know if they do that for like breast augmentation or breast reduction surgeries. A lot of those go on. I mean, there's risk. So keeping your own blood on board is the safest blood you can have. The next safest blood is not directed donation statistically. Oh, my Uncle Joe has the same blood type I do. I mean, if Uncle Joe wants to donate blood to replenish what you took out of the blood bank, that's fine. You are better off with blood bank blood, statistically. All my blood, of all those transfusions, and there were a zillion, I'd estimate more than 50 units of other people's blood, or was blood bank blood. Every time you get a transfusion, it's harder to do the match. It's called a cross match. It's not, certainly the first thing they look at is blood group and type. The group is ABO, all the different ones. We'll do a quick review of that. The type is positive, makes it positive or negative. When you add the positive or negative, now we have blood type. So, I mean, that's nomenclature, not a big deal. It is a complex process to do the cross match. So the cross match is actually finding the most desirable blood. Hi there. You need me? Need us?
No, we're just getting ready.
We're talking blood. We're going to do our blood lab. We're going to let them poke themselves or each other. And some with more force than others. They don't believe when you were department chair that you said it was okay to.
Yeah.
See, Dr. Badger doesn't agree. That's why I like Dr. Dress better.
Plus, I'm much better.
He's better looking. And he's more entertaining. I hope for all of you, you get to work wherever you work in an environment like this, with my colleagues here. Why do you think I want to keep coming in other than the money? It's just heaven every day, even if we have a bad day. There's nobody here who you couldn't go into and ask for help and they won't immediately give it to you. That's very lucky. I mean that very sincere. I'm not just because Dr. Dress is in earshot. I will repeat that again and again. Like I told my wife, maybe not until 90, 80, 85. So wheel me in, I'll be saying the same stupid jokes, references. No one, God, can you imagine in 10 years, nobody would understand what I'm talking about. They would know about Bugs Bunny or whatever his name was at the halftime show. I know, bad. They won't know, trust me. So the whole idea, if you lose, now I had lost 2/3, but if it happens rapidly, I would have been dead. If it happens slowly, chronic blood loss, I was functioning, treating patients, stupid. If that had happened initially, if I had had a bad bleed inside, if that had burst, a burst ulcer, and a bleed internally of that magnitude, I probably wouldn't be here giving this lecture. Let's say, to be very honest with you, very honest with you, I was close, really close, 2 times. One in 2000, I wasn't 50 years old. I had all these transfusions, and one in 2006 when I had a salmonella blood infection, not poisoning infection. My kidney shut down. We get to that in the kidney. Okay, so you got to restore it. If somebody's bleeding in a bad accident, stab wound, gunshot wound, you put blood in right away. If you're trying, as well as fluids and all that stuff, lactated ringers is an example of that, because it's like a mixture of salts and sugars, and it's trying to mimic the electrolytic composition, as you can see, of your blood. But it does, and then the transfusions that I got were all, I remember I told you about them, packed red blood cells. They siphon off the plasma to use. They siphon off the platelets to use. They siphon off the white blood cells to use. And that's packed red cells. The reason why that is such a good way is, if you did not know, HIV travels with the white blood cells. It doesn't mean there aren't going to be white blood cells in it, but that's where HIV travels. Number 2, hepatitis C typically travels in close proximity to the fibrinogen that's dissolved. That's why even before we knew that, packed red cells had a much, much lower rate of infectious disease than whole blood. You use whole blood when you have to, just to give you an idea. So whole blood, again, rapid and substantial, big accident, big injuries, sharp force trauma. Packed cells are preferred, because generally it's for oxygen carrying capability. Blood lasts for barely a month when you go to a blood donation. You didn't know that. So it's all about blood types. You know about this. This is multiple alleles. Rather than dominant and recessive, we have 2 dominants, codominant A and B, and we have a recessive trait. Why, in the world of genetics, is the most common blood type double recessive? Go figure it out. Can you explain this to us? Send me a memo. It's okay. Just joking. So you all, and this is really the primer of immunology. They have markers, glycoprotein markers. Short chain carbohydrates are the antigens. In the old days, we call that antibody generating. That's where they got their name. Now they're self and non-self. So your self antigens are the markers on this, and this is where the incompatibility. So, and we have agglutinogens, which are basically we are pre-programmed to make antibodies. And and I'm sure you've had this. If not, you're going to get it again. So mismatched blood will be agglutinated. That's why you see the little speckles, and destroyed. So as you can see, we have a lot of antigens. That's what I mean when you talk about tissue typing for donating a kidney or something along those lines. Or it's not so easy as just blood compatibility. There's a very elaborate number. It's for about 100 different antigens, and arbitrarily a large number. And if they're like a community is trying to do outreach for a kidney, then you look for someone. There's X number, means it's compatible. If it's not an identical twin, it's not yours. Identical twins, you almost always have it. There's rare instances called a chimera, but we'll go into that when we talk about immunology. Siblings are not always good matches. It just depends. Genetics are funny like that are there. So, and that's how they use this. There's lots of different, there's weak ones, there's strong ones. The big players are obviously the ABO system. Why? Because their transfusion reactions are so vigorous. Immunosuppressants, we can deal with the other stuff if we're talking about donating an organ or a part of the organ. Here, there's no wiggle room. And everybody freaking makes mistakes. Here's the other anecdote. Duke University Medical School. Top 10 hospital in the nation by any standard. I'll buy that. UPMC here, AGH would be in the same category. Big teaching hospitals. In the days before we did live liver donations, you had 24 hours to donate a liver. There was a whole liver was all really made from here. They had a liver candidate who was a young woman, a man rather, middle-aged man who was a candidate. He died just as the liver arrived. They looked in their records and immediately found what they thought was a perfect donor in a young woman who had some type of primary liver disease. They transplanted her. The first day she was fine. 2 days later, she was deceased. Nobody thought to check the blood test. The most important thing was an incompatible blood thing. Duke, not Bill's Hospital and Washing Machine Repair Store, Duke University. I can't even imagine the size. The tragedy alone, much less the size of the lawsuit, be monumental. Okay? So understand this is really important stuff for that. And anybody can make mistakes. How many people does it take to give somebody a transfusion in a hospital? Can one person do it? You're hanging an IV filled with a bag filled with blood and you stick a needle in it. One person physically could do that. Totally unable to do that in a hospital. You have to have at least two people to check the label on the blood, the label on the patient, the orders in the chart, the control numbers that are circulating, et cetera, et cetera. Okay. That way there's no slip-ups, not the word I was going to use, the other ups. That's a medical term. Fornicating ups. Would that be fornicatory? Fornicated. Oh, come on. Give me a smile. I know you want to get the fornicate out of here. I didn't say that. Swiped. I was trying to be humorous. So, again, you've all had this before. Type A has A antigens and antibodies to B. Type B has B antigens. Okay. Type A and B, and you'll see this. Let me just do it this way. It's easier. So what happens is blood may contain preformed anti-A and anti-B antibodies act against transfused red blood cells with ABO antigens not present in the recipient's RBC. And they form about 2 months of age, reaching adult levels early on. Voila. Classic chart. I used to draw it. The mistake, this universal donor, universal recipient has to be clarified. Okay? Type A, okay, the most popular common blood type, as you can see statistically across the board, is type O. That has neither antigens to A, has no surface antigens, neither A or B antigens, but it makes both antibodies. Again, when you have packed cells, effectively you don't even have a lot of antibodies in that. They're in the plasma. That's where they're found. They're dissolved there. So that's considered the universal donor. That's almost 100% right. RH, the factor that we'll get to, is another antigen. It doesn't include an antibody. If you're RH positive, okay, you have an RH antigen. That means your body makes antibodies to that if you're not used to it. So if it was O positive and you infuse that into someone who was negative, any kind of negative, they would have a reaction. When they don't know somebody's blood type and they come into the emergency room, the very first thing and the first blood that they lose over time, and what they always need is O-neg. That is the true universal donor. No antigens, no A antigens, no B antigens, no RH antigens. O-neg on the rapid infuser, go. And then type and cross match for type-specific blood on standby for the O. Standard order, you'll hear it. Listen to the pit, you'll hear it. Who's ever medically advising them knows what they're talking about. And I almost got the diagnosis the other night. I got the residence, the pemphigus, blistering all over the place. Told my wife, see, I'm still sharp. She goes, no, you're not. She also advised me to shut the front door. It wasn't even open. Please laugh at one of the jokes. AB, okay, has both, the beauty, it has both antigens. Your body responds to antigens. Antibodies get in the way, but antigens provoke the severe immune response. Foreign antibodies, when you hear about a baby being born with jaundice, typically there's a certain ABO incompatibility that's minor. It's antibody based rather than antigen based, and it's somewhat irregular. My texting middle son had that. Again, we're not biological, so I can't answer. My blood type's A+. Why it was a relatively easy cross match. But he had to go do the ultraviolet light thing because he had a buildup of bilirubin. He was jaundiced at birth. That's not uncommon at all. Nothing problematic about it. I don't even know his blood type. So the universal recipient is not just AB, but AB positive. So your body is well aware of all those three major antigens. Antigens to A, the A antigen, the B antigen, and the positive antigen. I have A. Antigens to A, antibodies to B. B, opposite. Surface antigens for B, antibodies to A. Imagine if those two mix. Probably what happened in that case I was talking about at Duke. Vigorous train. I had all those transfusions. I never had a transfusion reaction. First sign, fever. It's kind of like your immune system giving it a what's going on here. So there's a lot of RH factors. RH comes from, if you didn't know, comes from rhesus monkeys is where we identified it. That's why they call them RH factors, just historical context. One we're looking at is factor D. 85% of us, the typical thing when you do, the 3-to-1 ratio, RH positive, the reason it's higher than that, and it's true for most dominants, it's more closer to 80 or 85% because RH positive men are more likely to have babies with RH positive women. And so then that increases the likelihood dramatically. Okay. Unless they're, heterozygous versus homozygous. Okay. I don't have to reteach genetics. I better not. So they're not, and understand this is the problem. There's no antibody to it. So, and this is really the last nugget for today before my big blabathon is over, is anti-RH antibodies are not spontaneously formed in RH negative individuals. If an RH negative receives RH positive blood or a mom is carrying an RH positive fetus, problem. Because whenever that pregnancy ends, whether it is terminated, whether it's a miscarriage, whether it's a regular birth and delivery, stillbirth, doesn't matter. The mom is going to be exposed to the baby's blood, period, end of sentence. They will start to produce, every doctor knows about this. If she's getting any medical care at all, they are totally aware of this. And that second exposure, so the only ones, if you're RH negative, there's an element of risk. It's because you're more likely to have a child with someone who's RH positive by whatever means, in vitro, artificial, whatever you want to say. So we call it erythroblastosis. I want to make sure I'm in the right place. Erythroblastosis fetalis, a red blood cell disease condition, really. Okay, hemolytic disease of the newborn. Okay, because of those antibodies, antibodies can cross the placental barrier, and they will damage and destroy the baby's red blood cells. So and now RhoGAM has been around for a long time. Contains anti-RH and can prevent RH negative mom from being sensitized. Exactly what the protocol is, I don't know. So transfusion reactions are big problems because they clot. When they rupture, there's hemoglobin in the bloodstream. Not only is it diminished, the big problem is the kidneys. All that hemoglobin creates a real significant risk to the kidneys. So you almost have to be dialyzed for things to be, as well as the oxygen carrying capability and dealing with the vessels. So it's really It's a critical race. Fever is number one on the hit parade. First thing they said, go, Lou, when you get home, take your temperature every hour. If you notice an increase, call us. I didn't live that far. I lived relatively close to St. Margaret's at the time. I didn't live in, I lived in O'Hara Township. So donor blood is mixed with antibodies against common agglutinogens, blah, 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 blah. Okay. So we cross match. All those types of things are done. This is what you'll see. Okay. Basically, and this RH factor will speckle as well. It's the hardest one to read. Anti-A and anti-B are fairly easy to read. You have a drop of your blood. I have a different glucometer here that is new. I like these cards rather than the stupid plastic things. So you have 3 different drops of your blood. You can do with your finger on blood, blood, blood. The key is when you mix them with anti-A, rather here, anti-A, anti-B, anti-B, anti-B. Where's anti-D? Ah, I'll find it. And for the anti-D, that's really the one that's sort of the rate determining step. You can look at these that are part of it. They've done 3x5 cards. Please have the anti-D before I have hernia. Oh, help me, please. I'm looking. Don't give up hope. If I don't have this, I am such an idiot. Oh. I have to order this shit. Oh, heavens. We don't have this. I may have to do this next week. Let's see. Glucose. Oh, I thought everything was in there. This is unfair. Sugar in your glass. NDA, UTB. So let me make sure I find it because I'm done talking for now. Hold on, let me do this before I get panicky, which is certainly coming. We've had all the backstory. Let me